quick review of all of the materials that have been released, and I've kind of gone through all the PowerPoints and cross-referenced them with all the cheat sheets that are available. So hopefully this is a very condensed look at all the things we need to know in terms of the pathologies and the drugs. So we'll start with a little bit of scripture here tonight. I know we're pushing at the end of the semester, and most important now not to get tired. Keep pushing forward. And we went backwards this time. But what's on this exam? We're going to have a very detailed look at cancer. There are going to be 15 questions from just the cancer topics. In terms of chemotherapy in relation to cancer, we're not going to need to know drugs related to cancer. We're just going to need to know important overarching concepts about when I'm giving chemo to a patient. So what's important for you as the nurse to know when you're giving any chemo. We're also going to need to know dermatological drugs. We're not going to need to know every pathology of skin. We're going to need to know some really common ones, but we don't need to know everything that could happen to anyone's skin. We also don't need to know anything about skin trauma, so no burns, no lacerations. We're mostly going to look at infectious processes of skin and autoimmune pathologies of skin. We're also going to talk a lot about analgesics. This is the biggest class of drug that we will ever give, especially opiates. Opiates are the #1 drug prescribed ever. We're also going to talk about non-opiates and NSAIDs, sleep, drugs for sleep, and parasomnias. Those are going to be on this exam. Also antidotes to common drug poisons. So just as we give a lot of opiates, we'll also probably need to be very familiar with Narcan, which we'll talk a lot about. And also pain, key theories of pain, and then the management of pain. So first we'll look at cancer. We're going to need to be familiar with key terms with cancer, so knowing how to look at a word and say, I know where this cancer is, and I know that this cancer is typically malignant or benign. There's a lot on Otto's slides about that. So this is all available to you, so you don't necessarily need to take notes, but important words to know: adenocarcinoma, carcinoma, sarcoma, lymphoma, leukemia. Those are going to be important. Also know the cancer causes. Some are environmental, some are genetic. Some of them are going to be hormone related. So we know people with breast cancer, the longer you're exposed to estrogen, for instance, the more at risk you are for female cancers of the breast, of the cervix, etc. We also need to know a little bit about the staging and grading of malignancies. There's going to be some material on mock for that. But the TNM grading scale, local spread, and how local spread influences metastasis. So if our cancer is very aggressive locally, it has a very high chance of finding its way to a lymph node or the bloodstream. So kind of those are correlated topics that we'll talk a little bit about. Also need to talk about the clinical manifestations of cancer. So cancer is very metabolically active, right? It's just sitting there eating everything that it can get its hands on. So it's going to make our patients thin, they're going to lose weight, and they're going to get cachectic, which is a wasting syndrome. They also tend to be in a lot of pain, and cancer can erode bones, and it can put pressure on organs, and so there's a lot of pain that cancer patients can have constantly. And then hand in hand with these things, we've got weakness, we've got fatigue, we've got shortness of breath. We'll also talk a little bit about the biology of cancer. So angiogenesis, it's bringing its own blood with it. It's making blood vessels grow to it so it can eat. Cancer tends to proliferate a lot. So most cells, most somatic cells are controlled. This should be reviewed. And then the cell cycle, which I'm just going to give a quick blurb, just in case AMP was a long time ago for you. This is our cell cycle. There are quite a few rest periods and determination periods for cells. So the normal cell spends a lot of time in the G1 phase. Then it decides whether it needs to replicate. G2 is preparation for mitosis. So all of these phases are not divisional phases. So you can see the majority of time is spent not dividing. But it's this phase here where we're actually manipulating chromosomes that we're most worried about cancer risk. Because if something interrupts that phase, like a particle of radiation, or even just natural things that can happen with the aging cells, it can make it cancerous. And something can really affect the chromosomes and the way they divide, in which case then we've got cancer cells. So instead of these being lovely blue healthy cells, they could be angry, nasty cancer cells. Here's some actual pictures of cancer. Did Otto talk a bit about cancer in situ? Yes? Phillips did. Okay. This is a picture of normal epithelial tissue. You can see that it's very well defined. The layers are very well stratified. Here, things look thicker and darker, and the cells have changed. They're still generally in a layer, but this is where we're beginning to see some cancer cells and some kind of precancerous material going on. And here, things are not looking very stratified. Everything's starting to look like one kind of cell, and that's that cancer cell that's starting to divide and take over. And here it's so thick and random and weird, it's definitely cancer. So you can see the progression here from normal epithelium all the way to what the heck tissue is that even. But I think it's important because illustrations sometimes don't show you exactly. That's nose cancer. Talking about chemo now, nursing indications. So when our patient extravasates and that med goes places it shouldn't be, chemo is very caustic. Chemo lyses cells. So the longer it sits in contact with the tissues, the more cell death we've got at the site. This can be life-threatening. This can be limb-threatening. People will have their whole arm or wherever you put that IV removed, or at least very disfiguring. Life-threatening events can occur, though, especially if they become septic. So that's very important to monitor our patients for extravasation. Also lab values for holding chemo. So if we get a patient in for chemo, does anyone know the lab values off the top of their head? Okay, so absolute neutrophil count, or ANC, that's an important number. Less than 500, we need to hold back on our chemo. Total white blood cell count, so all white blood cells total, needs to be 2,000 or greater if I'm going to give this drug. If they have fever, if they have signs of infection, we're also going to hold it because they need to be able to fight that infection. And we'll talk a little bit more about drugs for white blood cell counts in a minute, just in very brief. Sequela of chemo, sequela just means bad things that happen. So chemo tends to be very hard on fast, quickly reproducing cells. So our hair cells, our gut cells, any of the cells that really are naturally fast dividers are going to take a hard hit with chemo. This is why our patients with chemo have nausea, vomiting, diarrhea, because they're sloughing those cells inside of them. And it's becoming diarrhea or vomit because the body's really not happy about all the sloughing. Alopecia, our hair falls out. Other adverse reactions, chemo is very high risk. Patients can go from walking and talking and breathing to anaphylaxis, hypotension, pyrexia, which is extraordinary high fever. So you need to be watching these patients constantly, not just for extravasation, but for sudden progression of symptoms. We talked a lot about, or not a lot about, but a little bit about ANC and white blood cell, also fever and infection. So if our patients come to us with signs of infection, we're holding our chemo. They're coming to us with low white blood cells and low ANC, we're holding that chemo and calling the provider. Other meds that are important to know about, steroids. Why are we giving our chemo patients or our cancer patients steroids? And what do steroids make us want to do? Eat. And our patients don't want to eat when they're on chemo because they've got nausea, vomiting, diarrhea, but they must eat. And so in order to stimulate some of those processes, we're giving them steroids. It's also going to help with some inflammation and arthralgia. A lot of patients have joint pain on chemo, but mainly we want them to eat. High-dose steroids will also cause euphoria, and anything that we could do to elevate their mood, great. Analgesics at the site, we could use Enla, because these people are getting poked a ton. They might also have a port, but in many cases people will do, just, if it's a short stint especially, they'll do peripherally inserted stuff, and that hurts after you poke them and poke them and poke them. Promethazine, that's Phenergan, and that's driving down our vomiting response. Also, Ondansetron, which is Zofran, acts on the brain, suppresses vomiting. So both of those drugs are good for our patients who are constantly vomiting. Here's a picture of extravasation. You can see that the tissue where the IV was is quite necrosed, and hopefully they can get that surgically debrided. Here's a picture of Zofran. We're giving this for vomiting. Why are we giving diphenhydramine? Does anyone know?
Antihistamine.
It's an antihistamine. So if our patient, why might we give an antihistamine? With chemo. So maybe they're having an allergic reaction because these are very high risk. So we're going to give them this if they are suddenly having an allergic reaction. Diphenhydramine can also help lessen vomiting and produce slight sedation. Promethazine is our Phenergan. This is also a pretty high-risk drug, but it's good at controlling vomiting. Neulasta, this is a short little stump about Neulasta, or pegfilgrastim. This is a stimulator. It's a colony-stimulating factor. So our white blood cells are going to proliferate on this drug, and that's good because we don't want our patient to have too low a white blood cell count, otherwise we can't continue their chemo. What is it called when our patients when they have their first drug hit, their white blood cells come down and now they've plateaued? What is that plateau called? It's an important term. Nadir, N-A-D-I-R. So after their first chemo, we're going to take labs from them to determine their nadir, and then we'll schedule their next chemo. And that's important because if we just randomly or arbitrarily put people on chemo, we can crash their immune systems, and they'll get a huge infection and die. So nadir, N-A-D-I-R, I guarantee that will show up at some point. Solumedrol, this is our prednisone that we can give patients to stimulate their appetite and decrease inflammation. And then Emla-Cream, and this is going to be a part of our skin prep too, but we can use this for people who have multiple vein punctures. So if we're poking them constantly, let's numb that skin so it's less painful for them, because cancer patients already have enough pain to contend with on a daily basis. But remember this for skin too. This is an anesthetic for skin. Rub it on and you lose sensation. Just flip past it. No, okay. Final bit about cancer. These are just some random facts that were on the cheat sheets. H. pylori, Helicobacter pylori, can cause gastric cancer because it inflames the gut and the upper gastrointestinal tract. Also, chronic inflammatory processes increase our risk of cancer. So our Crohn's and colitis patients have an increased risk of GI cancers. Also, our rheumatic process cancers, increased risk for bone cancer, increased risk for certain other cancers. So anytime you're dealing with a chronic inflammatory response, think risk for cancer. Pain and sleep. Pain